Dana Miller presents the 9th Annual Obesity Conference, a practical look at obesity, diabetes, and current strategies. Featuring Ovidio Bermudez, MD, the dual diagnosis of eating disorder and diabetes mellitus.
I'm happy to introduce a rock star in the eating disorders world, Dr. Bermudez. He's a fellow of the American Academy of Pediatrics, the Society of Adolescent Health and Medicine, the Academy for Eating Disorders, and the International Association of Eating Disorder Professionals. He's past chairman of the senior advisor on media for the board of directors of the National Eating Disorder Association, a co-founder of the Eating Disorder Coalition of Tennessee, co-founder of the Oklahoma Eating Disorders Association, and founding member of Houston Eating Disorder Specialist. He's a certified eating disorder specialist of the International Association of Eating Disorder Professionals in the field of eating disorders. He just has just so well known and is one of the leading experts in the United States. I had the opportunity both of attending some of his lectures and learning about the field of eating disorders with him and his colleagues at Eating Disorder Center in Denver, and I think you're going to really enjoy this. It's just really fascinating. Dr. Bermudez, thank you.
Well, good afternoon. Thank you for the invitation. And, I've been sitting, kind of listening for the last couple of days, feeling like I'm a freshwater fish swimming in the ocean. And then my talk comes after the sexy talk, and I said, okay, that's it. That's it. So what I hope to do is, I was asked to talk with you about this interesting phenomenon of the intersection between really type 1 diabetes and eating disorders, eating pathology. But I wanted to start by, no conflicts to report, by, I think, sharing with you some thoughts about common ground between the obesity fields and the eating disorder fields. I think John said it well. In so many ways, I sit and listen and talk about a mirror image. And, it took a long time for, I think, the world to recognize obesity as a biological illness. And I think we're just getting there in eating disorders. I think we've blamed so many other things. We've blamed parents, we blame society, we blame behavioral issues, and at the end of the day, we're probably talking about more similarities than not when it comes to neurobiological derangement and what it means, for the brain to control the way we eat, we relate to food and nutrients and the like. This is the current sort of schema according to DSM-5 of eating disorder diagnoses, and probably the most commonality is with binge eating disorder. Two facts that I think are important is that the majority of people with binge eating disorders are overweight or obese. And in the eating disorder literature, it is said that about a third of patients seeking weight loss at under any clinical circumstance would probably meet criteria for binge eating disorder. And I think the important differentiation to keep in mind is that binge eating disorder, like all the other eating disorders, are serious mental illnesses. So there is a difference between struggling with overweight and obesity from the perspective that we've been discussing here in the last 2 days, and versus from the perspective of being seriously mentally ill. And that's really important to keep in mind. Another possible intersection is bulimia nervosa. So the majority of patients with bulimia are normal weighted, right? So in spite of engaging in the recurrent cycles of binge and purge behaviors, the majority of patients are normal weighted. But there is sort of a section of that population under that diagnosis that is underweight, and then another that is overweight. And of course, bulimia and binge eating disorder, even though they share the binge eating behavior, they're actually quite different entities. And so I think from your perspective, that to me, that's important to think about. The other notion is that under OSFED, under other specified feeding and eating disorder, there is now a subcategory that is relatively poorly defined and newly defined that's called atypical anorexia nervosa. And atypical anorexia nervosa should be of interest to you because it refers to a syndrome in which an individual that starts overweight develops anorexia nervosa, all the medical characteristics, all the psychological characteristics, all the medical risk, including the high mortality risk, and yet, as they drop weight precipitously, they may land still overweight or normal weighted. So it's a person that has had a drastic change, has developed a serious mental illness, i.e. anorexia nervosa, but the atypical component is the fact that they are not underweight as you would expect anybody with anorexia. And that's a syndrome that we have to keep an ear to the ground on. So let's talk a little bit about then the intersection of diabetes and eating disorders. And I'll tell you that there's two possible relationships there. The first one, and the one that I'm going to focus on, is that having type 1 diabetes is a risk factor for the development of eating pathology. We'll talk pretty good at length around that. But the other possible relationship is that having binge eating disorder is a risk factor for the development of obesity and hence type 2 diabetes. And that's important to keep in mind as well. I've done some work with the bariatric group in Rio de Janeiro, and that's very much an area of their interest. So important to keep that association in mind. It also reminds me to just touch base on the fact that post-bariatric eating disorders are hitting real time. So we are obviously seeing people that post-bariatric either had and continue to manifest binge eating patterns, binge eating disorder behavior patterns, or acquire binge patterns when they didn't before, or develop post-bariatric anorexia. And I have seen that with almost all of the bariatric interventions, so I don't think that one is more or less likely to land an individual there. And post-bariatric anorexia, in my clinical experience, is quite an interesting syndrome, quite a phenomenon, if you will. So historically speaking, if we think about type 1 diabetes, rich history, and really differentiating in the last several decades from the discovery of insulin in 1921 to the definition of two types of diabetes, not until 59, so sort of yesterday. And with anorexia, we also have a very rich history, dating back 300 years or so, or a little more, when this British gentleman, Richard Morton, described in a book he wrote, a compendium on thinness. Thesis means thinness. He described phthisis nervosa, and it was fascinating for two reasons, two important reasons to think about eating disorders in general. The first of which, so I'll tell you the story. You know, in Europe in the 1600s, there were lots of people dying of thinness, and he essentially described three major groups: the group that coughed, lost weight, and then died, tuberculosis, right? The group that lost weight, began to lose sensation in their lower extremity, shuffle their feet, and then they died. They had chronic syphilis, right? And he said, look, both of those groups of people really feel bad, and they're raising their hand and saying, look, I'm dying, help me. Something is very wrong in my world. But then there is this small third group that he called phthisis nervosa, and he said, these people say, quote, I feel well, therefore I must be well. Essentially, leave me alone. And of course, those are two very different stances for people who are getting thinner and quite medically ill and dying. So that, in a sense, described the whole notion of ego-centonicity versus ego-dystonicity. And so from the primary care world perspective, we need to remember that eating disorders, by and large, tend to be ego-centonic. So these are not patients that are going to come and tell us, this is my problem. I think it's a little bit like the question of, how's your intimacy? If we don't ask, we don't get the question answered. And so it is with eating pathology and its egocentric nature. And then it wasn't until 79, so similar history in a sense, that bulimia came into the picture, described by Gerald Russell, really as a variant of anorexia, as a malignant variant, and then in 1980 it made it into DSM. So historically speaking, we certainly have seen an increased incidence of eating-related pathology across the world even in places where it doesn't make as much sense as one would think. Very much in the sort of under the auspices of genetic environment interaction, very much eating pathology should be thought of in some ways as culture-bound syndromes. So we have places like Japan, for example, where in Tokyo, we have some of the highest incidences in the world of anorexia and bulimia. But in the rest of Japan, actually quite low. So a Japanese villager has a very different experience and hence risk potential for this than a Japanese living in a metropolis like Tokyo. So that's important to think about. And we know that the incidence of both types of diabetes is very much on the rise. As a matter of fact, diabetes is the fastest growing disease worldwide, not just type 2. You could say, well, that's related to weight, but type 1 as well, which is not related to weight. Important to think about, and perhaps that's how these two illnesses came to collide in a way, because otherwise they're coming together wouldn't have made sense. You know that, so we'll skip over. And I mentioned this already. I'm sorry? Okay, thank you. So we'll focus on this association, not on the eating disorder and type 2 diabetes association. There's been a plethora of evolution. I think one of the talks today mentioned this. This was the first insulin pump in 1963. That's a far cry from the conversation we had about what's out there as far as health technology and the like, which it's can be quite sophisticated in the way that we monitor glucose and I think are coming closer and closer to mimicking pancreatic function from an insulin availability perspective. And then in eating disorders, we've seen significant evolution as well, because what's out there is a plethora of new terminology related to valid presentations of eating disorders that don't have diagnostic criteria. And things like, I don't know if some of you remember the movement of caloric restriction for longevity. It's really died off some, but it was primarily men, middle-aged men, financially successful, highly educated, who began to restrict under the auspices that caloric restriction increased lifespan. And it turned out that that was true for worms and for mice, but it turns out to not be true for humans. Just like being overweight is, lowers our lifespan, being underweight for humans lowers our lifespan as well. And then things like anorexia athletica, the whole notion of orthorexia and health dysphoria. We now, it's not just about body dysphoria or muscle dysphoria for men, but also about the whole preoccupation with health and living just right. Important and uncanny. And so I think you get the idea. The whole notion is that presentations related to eating pathology are becoming more varied, wider, different, novel in ways that I don't think that we would have imagined in the past. The whole notion of somebody developing eating disorder behaviors, particularly during pregnancy, for example, right? It's a little bit foreign. It's counterintuitive, if you will. So one of those terms that has come to be pretty well known in the press is diabulimia. The reason that this term came up is because the original descriptions were people who would binge eat and not cover, people with type 1 diabetes who would binge eat and simply not cover the binges with insulin, right? That was their mode of purging. Hence the notion that it was a bulimic behavior. It was a purging or compensatory behavior related to diabetes, and that's how the term came to be. I don't particularly like it. I don't think it's a good term to use with patients. I think it is not just about not compensating. It's not just about purging anymore, and it has that little diabolical connotation that I don't think is healthy. So ED, DM type 1 is probably better terminology, or the dual diagnosis of eating disorder and type 1 diabetes. So let's go through some of these and hopefully you'll have a better idea, because it's another entity that if you don't ask, they don't tell. So the definition is broader now than the term diabulimia intended, and it refers to the intentional omission of prescribed insulin. If you don't have type 1 diabetes, this doesn't work this way, by either strategically decreasing, delaying, or completely omitting insulin for the purpose of inducing hyperglycemia and rapidly losing calories in the urine, usually in the form of glucose, dose weight loss, or avoidance of weight gain. That's what patients are thinking sort of as this happens. But I think it's important to be thoughtful about how sophisticated this has become, because dose delays, decreasing the dosing, or insulin omission can all be kind of part and parcel of what happens. A lot of these patients will go to great lengths to not be discovered, if you will. Again, it's by and large an egocentric illness, so they'll disable insulin. So some of them may be in a position that they don't have to use insulin, but if they do, like teens, for example, parents may get suspicions and be watching, then they can either heat expose or microwave insulin, and that renders her useless. Some of them develop techniques to impair absorption, so they'll actually use insulin, but in a way make it useless, such as repeatedly injecting in areas of atrophy or induration, or what they call leaking shots. And it's fascinating. They say you don't know anything about eating disorders until you sit down with a group of people with anorexia nervosa and eat with them, right? Because that's where the rubber meets the road. With this is a little bit like that. It's really uncanny to watch how creative and crafty these patients can get. So these patients that are taking shots, for example, learn to leak the shots on the way in. So they'll measure insulin, right, and start to move that plunger. And by the time the needle is into the skin, there is no insulin going in. Or they learn to do it the other way around, right? They put the needle in and they start to pull as they move the plunger in, so the insulin eventually ends up outside of the body either way, in either direction. So they get crafty. Some people still underdose for binges, or do not dose for binges, and of course with the use of pump manipulation is rampant. So here is a list of what people can do with a pump. One of our practices when we treat patients who become seriously compromised with this is that if they've intentionally manipulated their insulin and they're using a pump, we start by interrupting pump use. There is no way to stay ahead of that ball game. So it's a cat and mouse game that clinicians lose by and large. So again, relatively crafty ways to make things look as good as possible. But at the end of the day, the insulin is not bioavailable, therefore the weight loss ensues, and that becomes a real problem. How sophisticated they get, I'll tell you a little story. I know we have a couple of endocrinologists. This doesn't look too bad, but this was a 40-year-old OBGYN nurse with a 25-year history of insulin dependence, and clearly using what these patients come to call dead spots. So they continue to use insulin in the same area, and the induration makes the absorption of insulin at best erratic, if not none. And so fairly sophisticated type of approaches. They can also work on making blood sugars look good when they're not really good. Obviously, you see here a couple of those ways in which it can happen. And interestingly enough, I've had patients as young as 12 years of age tell me that ketchup is kind of the perfect substance to trick their parents because, it's red. So important. So risk factors. Why do we think this is happening? And I think there's a series of risk factors associated with the experience of having type 1 diabetes that are meaningful setup for someone to develop eating pathology. So you know that with the onset of type 1 diabetes, there is usually weight loss. And as soon as they initiate insulin therapy, they gain their weight back. Right? Kids will tell you, this happened to me when I was 5, but I didn't miss it. I noticed it. So I know. Kids with type 1 diabetes trends towards higher BMIs in general compared to age match, gender match peers. And then dietary restraint is taught. The diabetes education movement is one of the more successful healthcare movements that the world has ever known, right? It's consistent, it's the same everywhere, it's fantastic in so many ways. But part of that success is the price we pay for teaching these patients meal planning and carb counting, which is still important for insulin dosing, no matter how you slice it. So when it falls into the right brain, this is wonderful education. But when it falls on the wrong brain, then it's education that's really sort of promotes a focus that they're already inclined to have to begin with. So they learn dysregulated eating based on external cues, right? If you've taken your insulin, you have to eat. It's not really a choice. So the whole hunger and satiety cycles become disrupted on account of lifestyle. I mean, we know in your populations we can make them better by improving the lifestyle. Here's where lifestyle can actually turn things a little bit south, if you will. Exercise and its relationship to glucose management is important, and these patients come to understand it often at quite an early age. And then, of course, they can omit insulin. And of interest, individuals with type 1 diabetes have 2 to 3 times the depression rate of age-matched peers. So there's probably more to diabetes than meets the eye from a neurobiological function perspective, right? Like there is more from a biological perspective, and we'll share that a little bit as we think about pathogenesis. So this is the current model that speaks to how this happens or why this happens. It's called the modified dual pathway. And it essentially says that if you follow the solid lines, these are things that we've known for quite some time, right? If you get diagnosed with type 1 diabetes and you begin exogenous insulin administration, then you tend to gain weight. Because of that weight gain, you tend to develop body image dissatisfaction. That can lead to negative affect, exacerbated by the frustration of blood glucose fluctuations, and patients are more likely to engage in disordered eating behaviors. In addition to that, there are other components of this model now. This is where the modification comes in, and that is that a dietary regimen tends to almost always end up feeling like dietary restraint, and that tends to sort of feed the whole negative affect, frustration with weight fluctuations, weight gain, negative body image, and it all tends to end up towards, hey, if I have a tool that I can use, why not use it? Of interest, in talking to patients who meet diagnostic criteria for ED, DM type 1, they'll tell you that, if you talk to their peers, everybody who's got diabetes is fooling around with their insulin in this day and age. Now, everybody's a long word, right? So I don't know that it's about 100% of people, but I think it's a much higher percentage of people that actually engage in the disordered eating behaviors. Not all of those are going to go on to develop a mental illness, but some of them will. So at the end of the day, this is summed up by the disease-based mechanisms: carb counting, driving imposed food preoccupation, weight fluctuations associated with variable use of insulin and subsequent body image dissatisfaction, blood glucose fluctuations associated with a mismatch in insulin dose, excessive caloric intake as a response to hypoglycemia and resultant weight gain, again, sort of feeding back to negative body image. And the response to hypoglycemia sort of triggers, is almost a little bit of a training for binging, right? When you become hypoglycemic, after a while, then you eat, and after a while you overeat. But it's certainly difficult to regulate because it's not under the normal parameters of hunger and satiety. And there is more at play. So we also know that amylin and ghrelin functions are disrupted. So there is more to diabetes than my sugar is high or my sugar is low. I think that there is a mounting body of evidence that speaks to the fact that type 1 diabetes has broader repercussions in biological function than just the ability to produce insulin or not. How common is this? I've summed up probably 20 articles around epidemiology, and I think 3 things are clear. One, there is increased prevalence 2 to 3 times of both subthreshold and full syndrome eating disorders in females with type 1 diabetes. It should not be any different in males. It's just that we haven't studied males. So the statement can be made about females. It's significant. Insulin omission or insulin reductions tends to start early in preteens. So there are studies that have looked at populations of type 1 diabetics and have identified 9 as the age in which this tends to really show up. So it seems like 6, 7, or 8 it's not what's happening, you know. But as soon as they hit 9 and 10, this seems to come onto the table. And then insulin misuse tends to advance with age through adolescence and the college years, and then it tends to drop off significantly. So the picture of the woman that I showed you manipulating her insulin in her 40s is an unusual phenomena. But the ear to the ground is that this is an age of autonomy, right? So this is an age in which diabetics are taking care of their own diabetes. When they're little, parents are around to watch. So this is a time when they tend to really get in trouble, if you will. So important to think about, and that's a little bit of what supports that. What do we see clinically? Well, what we tend to see clinically is, first of all, patients with type 1 diabetes that begin to lose weight. And there should be, no justification for that unless it's been prescribed somehow for, a medical need or something like that. Weight loss is an important marker of derailment of health as weight gain is. And I think that's important to sort of think about. Of course, in your population, that's not true up to a point, because then when I see them in the other extreme, the few people who develop post-bariatric anorexia, for example, it's clear that they sort of cross a line beyond which weight loss becomes clearly not in their best interest by any means, shape, or form. We also tend to observe poor diabetic control, elevated A1C, sometimes in spite of reported good diabetic management, if you will. Recurrent DKA, telltale sign, right? If there is not a good rationale otherwise, then why? Especially in the latter teens, college-age kids, in which they're more responsible for their own care. And there is very, very good data of these two facts, either early appearance or rapid advancement of microvascular complications that had already been identified. So both of those, right? If you begin to see microvascular complications in a time frame living with type 1 diabetes that you wouldn't expect it yet, you have to ask why. And if you see rapid advancement beyond what is sort of expected, if you will, we have to ask why. At the end of the day, I think the most important sort of clinical feature to keep in mind is weight loss. If in your practice a diabetic has had sort of a history of stability and they present with weight loss, there is usually a problem in this scenario, if you will. So important to think about. In addition to that, there are two factors that are important to keep in mind. The first is the high morbidity risk, both associated to complications of diabetes, but also to complications of anorexia. So this is a bit of a double whammy. I always remind students that people with anorexia can develop appendicitis too, right? If all of a sudden they have right lower quadrant pain, you might want to think about calling your friendly neighborhood surgeon. So, just because they have anorexia, that's not their whole world, right? That's not the whole existence. And in this is a little bit, we have a combination of two illnesses, two severe illnesses that have their own morbidity and mortality risks. So pretty good data in this case. This is out of Toronto, and 91 cases followed with disturbed eating behaviors at baseline, and then at 4-year follow-up, 3x the rate of retinopathy in those that were manipulating their insulin compared to those who were not manipulating their insulin. So the advancement of the comorbidity is fast and has been, I think, fairly well documented. And then just as important, and if you haven't heard it, it will be good to hear it now, right? You've heard or may have heard that anorexia nervosa carries the highest mortality rate of any psychiatric illness known to man. Higher than schizophrenia, higher than bipolar disorder, higher than borderline personality disorder, right? And that includes suicide risk. So there's a higher risk of suicide in anorexia than there is in major depressive disorder, in bipolar disorder, and in borderline personality disorder. So that's important to think about. Well, it turns out that if we were going to modify that statement, EDDM type 1 actually has by far the highest mortality rate of any psychiatric illness known to man, and actually 5 times that of anorexia. So Nielsen has published on this twice. First time was a 10-year Scandinavian registry study, and that looked at deaths per 1,000 person years. So for type 1 diabetes alone, in that sample there were 2.2 deaths per 1,000 person years for diabetes alone, 7.3 for anorexia nervosa alone, and 17 for the combination of, 34.6 for the concurrency of eating disorder and diabetes, and that's 17 times the mortality rate of diabetes alone and 5 times the mortality rate of anorexia. This actually correlates well. We know that the crude mortality rate for anorexia is around 6%. Another way of thinking about it is 5% per decade of disease. The longer you live with anorexia, the more likely you are to die of complications of it. So the system sort of tires down. But pretty good evidence to talk about this is actually the psychiatric illness with highest mortality rate by far. And then management. We've created, we're a tertiary care center, so the people that get to us are people with eating disorders that have already had a pretty serious course or are complicated, if you will. So we've developed a fairly sophisticated management protocol for these patients. My interest in this began with patients, but in 2009 I was invited to a consensus conference at the University of Minnesota. And they brought in a group from Toronto, a group from Oxford, several groups from the West Coast, and then sort of clinicians throughout the United States. And that consensus conference led to a series of papers, and I'll share some resources around that with you. But this was one of the important conclusions of that was hatched out by this group. All patients with type 1 diabetes who are diagnosed with an eating disorder should be considered for in-hospital stabilization or eating disorder inpatient treatment due to their high morbidity and high mortality risk. So I think it's an important statement that really speaks to how frail this population can be and how important it is, number one, to have high index of suspicion to recognize them. Number two, if you make the diagnoses, to really size up what is their immediate risk, because their immediate risk can be life-threatening and significant, if you will. Our management approach is really in steps. So we begin with a pretty thorough medical assessment that looks at the complications of diabetes. If a patient is in DKA, that becomes a priority, if you will. But also the complications of anorexia. So these are patients that can lose massive amounts of weight in very short periods of time and tend to end up with many of the complications that you know about anorexia, especially cardiovascular, severe bradycardiac conduction abnormalities, significant gastrointestinal dysfunction, significant brain dysfunction, which is one of the interesting aspects of anorexia, is that the brain can really misfire. And I think we need to view that in all probability, the mortality risk is related to the fact that these complications can really feed off of each other. So if you develop DKA and you're already a debilitated patient that weighs, 60% of you're supposed to weigh and your heart is beating 25 times a minute, you're not going to tolerate DKA in the same way that you're going to tolerate it if you were a relatively more stable host, if you will. We also take into consideration the importance of a psychiatric assessment. So looking at psychiatric comorbidity, a severely depressed patient in a context like this can certainly only add to the complexity and take into consideration their safety risk. So these are not patients that are exempt from the suicide risk that other individuals with eating disorders also carry. And we've already begun to see, I think I'm going to share with you some of that, some safety issues related to self-injurious behaviors. Some mundane, patients that cut and burn, but some sort of very specifically focused on their diabetes, like patients who use diabetes paraphernalia to actually harm themselves with, which is, in psychiatry, it's a little bit of a challenge because, you know, if you have a favorite cutting blade, I can take that away from you, right? Like I can lock up a gun. But it's hard for me to say I'm going to take away your diabetic materials. you need those. That becomes difficult. And in our case, considering the readiness for change becomes quite important. It's actually one of those things that really needs to inform us as to how do we act first. So that whole notion of consideration of hospitalization, you have to convince me of a very high degree of readiness for change. Another aspect of ego-dystonic, ego-centonic illnesses is that psychoeducation is insufficient to alter behavior. And that's really important to keep in mind, right? So you don't tell somebody with panic attacks, just go home and chill, right? Chances are that that's not an intervention that's going to work. And it's the same thing with this. These people with type 1 diabetes tend to be very well informed as to the complications or potential complications of poor care of their diabetes. So sort of educating them about the trouble they might be getting themselves into or they've gotten themselves into tends to be insufficient to actually change their behavior. We consider the risk of travel if you're referring to a tertiary care center. That's important. And I think it's critical for clinicians to formalize the diagnosis of eating disorder and type 1 diabetes. So we're talking about an entity. So talking simply about the association and the risks involved in the association, in my opinion, is insufficient to actually get across the message that they have now crossed the line into an entity that you know carries all the implications that we've been discussing about. I think that we've come a long way in moving mental health into the primary care arena. People like Dr. Lazarus, I think, is a good example. I was really amazed how well versed he is with psychopharmacology. But the reality is that we're not where we need to be yet. I think that we need to move further along those lines. Our approach is, with these cases, once hospitalized, is an assume then resume approach. So our staff takes over the care of the diabetes 100%. Then we establish a joint effort of caring for diabetes, obviously with the goal of the patient resuming responsibility for their own care, commensurate with their developmental state and the skills that they have demonstrated as they gradually wean from staff supervision. So it's a little bit of a process. For many of these patients, this proves to be quite difficult, right? I've lived with diabetes 15 years. You know, how can you go back to the basics and you're going to now teach me what to do? And I think that the answer is yes, that's exactly right. They don't always like it. From our perspective, consistency is imperative. If you're managing this, it's really important to institute protocols both for glucose testing and for insulin administration. The whole notion of permissive hyperglycemia is an important one. I think that a lot of these patients who have, and by the way, we see hemoglobin A1C in the 14, 15, 16, 17% range. So, you know, when I think the conversation this morning was about, 6 or 6.5 or 10, I was saying, oh my gosh, that's not what I see. So these are patients who've, they've done what they had to do with intent, in a sense, to end up with a hemoglobin A1C of 15 or 16%. And then they come into our hospital and become absolutely obsessive about the adequacy of blood sugar regulation. So, if they hit 200, they panic. And I'm saying, well, wait a minute, you were just living in 600 and 700. Where's that panic come from? So we explain the concept of permissive hyperglycemia, and that's important. So lots of structure, expert multidisciplinary team. We do diabetic teaching retraining. Again, not always popular. And then we tend to address things like the frequency with which they become very obsessive about these things. And again, these are people who are struggling with a mental illness. So I think that's part and parcel of that shift that we tend to see from sort of being very permissive with oneself to being over preoccupied with the notion of control, if you will. We prepare them for weight gain, because if they've lost weight under having no insulin and we institute adequate insulin therapy, weight's going to go up. That's predictable. We tend to not teach anything about special foods. This is not about a diet or a dietary approach. This is about healthy management of two serious illnesses that are co-occurring. We educate us to the risk and benefit of exercise, and as you know, exercise very helpful in all the discussions that we talked about, except when your metabolic stance is catabolic. So if you are extremely underweight, exercise becomes counterproductive to in any way, shape, or form that you want to sort of think about it. And of course, I mentioned that we start without the pump, and eventually they'll resume insulin pump when appropriate. It's interesting that some of the patients that respond best to treatment, that seem to sort of adhere to the notion that a change is necessary, many times will elect to push away resuming pump use. They actually like the safety, the sense of safety in going back to the basics of subcutaneous insulin and the like. So, to conclude, eating disorders more common in individuals with type 1 diabetes than in the general population. That's important to think about. Probably in both genders. We know more about females. These conditions affect not only the physical but the emotional health of individuals with diabetes and are associated with the dysregulation, impaired metabolic control, the high risk of complications, and the high mortality rate. And I think clinical care should only be offered in patients that have been, I think, in a bona fide way identified with having this dual diagnosis in centers where there is significant expertise, at least to get the ball rolling. At the end of the day, it's always a partnership. So one of our problems is that no matter how well we take care of patients, they got to go back to their communities and they got to go back to their medical homes. So it becomes a partnership no matter how we slice it, but I think the initial steps should be taken very seriously. I mentioned just even more recent nuances. So I mentioned a little bit about the self-injury with diabetic paraphernalia, both cutting and stabbing that we've seen. So these are in lieu of cutting and burning, if you will, with other types of objects. And we're now beginning to see a phenomena of deliberate induction of hypoglycemia. And I've ran into two PhDs in their 50s, one of whom died of complications, and essentially both seeking thinness, because if you induce chronic hypoglycemia, you also lose weight. It's also interesting. And then we ran into this phenomena of insulin overdosing, so completely the opposite of everything we just talked about. We've had 3 children, and they've all been children in the hospital, who essentially felt so ashamed of their binging tendencies or urges that they would triple dose on insulin and then would have no choice but to binge. So fairly sophisticated and fairly deliberate sort of manipulation of their diabetes and baseline disease. Heads up to the wise, I think that The intersection of medicine and eating pathology has just surfaced, right? We were not talking about the misuse of this of insulin in diabetes until very, very recently, and we're already running into other phenomenology, medical phenomenology that really impacts an eating disorder. So eating disorder in patients with hypothyroidism and significant abuse of thyroid hormone, eating disorder and hyperthyroidism with intentional underdosing of thyroid suppression agents, eating disorders and cystic fibrosis, intentional underdosing of absorption enzymes, essentially allowing for malabsorption to occur in patients with cystic fibrosis with primary GI complications. We've also seen patients with primarily pulmonary complications overuse their vests. So you know that in cystic fibrosis, you remember how we did cupping to loosen up the mucus? Now there are vests that do this, automated in an automated fashion. And of course, if you absolutely overuse those vests, and in eating disorders, right, in compulsions, people can go to the hilt. And this is one of those areas in which we've seen people go to the hilt. We've also seen in inflammatory bowel disease, underutilization of anti-inflammatory agents, again, allowing enough inflammation to malabsorb nutrients, thus leading to weight gain. And these are not things that people can use their illness to manipulate in any sense, but we've ran now into cases of Turner syndrome and cerebral palsy and eating disorder. And as you can imagine, what a setup for these people who already have significant body image issues and the like. So important to think about it. A couple of resources. The proceeds of that consensus conference that I mentioned were published in Diabetes Spectrum in the summer of 2009. This is still quite relevant today. I think we've learned maybe a little beyond this, but really not much. And then this is another helpful resource if you're interested in eating disorders. This is a guide to medical care and complications of eating disorders, edited by Phil Mailer and by Arnie Anderson. And there is a chapter in this book on ED-DM type 1, its care, and a lot of the things that we have discussed today. So I think that covers my time, and I'll be very happy to take any questions or any comments or any thoughts.
This has been a Dana Miller Video Network presentation.